Health Director, North Central Railways, Allahabad, and Dr. A.P. Patnaik, who is Additional Chief Health Director and Physician, Central Hospital, Garden Reach, are moderators for this session. Dr. C. Bhattacharya and Dr. S.B. Chattopadhyay are to speak in the first topic, for and against the motion.
Good noon. Now the topic are properly detailed. We have two topics. First is the bicarbonate therapy is helpful in critical illness cases. Through Dr. C. Bhattacharya, he will speak on the floor, and one is Dr. C. Bhattacharya. I would request to Dr. C. Bhattacharya to speak on the floor about the bicarbonate therapy is helpful in critical illness cases.
We will give you 7 to 10 minutes to speak, and after which we will be open to the house to discuss.
Good afternoon, respected chairperson, my important KMBs, and my ACD Dr. Basu. I will speak in the motion of bicarbonate and acidosis, whether it's a milk pack or the ignored. So, normal blood vessels are like that, everybody knows it. So, acid-base disorders are very common clinical problems. We call acidemia when the pH is less than 7.27 and alkalemia when the pH is more than 12.44. Acidosis and alkalosis are used to describe how the pH changes. The primary cause of acid-base disturbance and abnormalities in the respiratory system or in the renal system. Metabolic acidosis is the primary cause in the bicarbonate concentration due to either a gain of acid or a loss of base, usually the bicarb. Acidemia refers solely to a fall in the pH. We gain acid from the exogenous source like ammonium chloride, endogenously from abnormal lipid metabolism, diabetic ketoacidosis, abnormal aldehyde metabolism, lactic acidosis, normal protein metabolism, that is uremic acidosis. Food and Curds did an online survey and on how intensivists and nephrologists get bicarb to the patients with metabolic acidosis. They found 40% of the intensivists would not give bicarb unless the pH was less than 7. Only 6% of the nephrologists wait until pH gets more worse. More than 80% of the nephrologists consider the PCO2 in making their decision to treat. Only 59% of intensivists do. In patients with lactic acidosis, 86% of the nephrologists treated with bicarb, and 2/3 of the intensivists give bicarbonate, that is p-value less than 0.25, that is statistically significant. 60% of the nephrologists treat decay with bicarbonate. 20% of the intensivists give bicarbonate to patients with decay, and it is again p-value less than 0.21. That means it is also statistically significant data. Both would administer bicarbonate by constant infusion targeting an arterial pH of 7.2. 75% of the nephrologists calculate the amount of the bicarbonate required, while only 1/3 of the intensivists do so. Metabolic acidosis results from a loss of the bicarbonate, that is a diuretic, or from its titration to an anionic base that often can be converted back to bicarbonate at decay or lactic acidosis. This non-bicarbonate based anion is commonly termed as potential bicarbonate, that can be changed to the bicarbonate again. So giving bicarbonate to a patient with a true bicarbonate deficiency is not a controversy, but controversy arises when the decrease in the bicarbonate concentration is the result of its conversion to another base, which given time can be converted back to the bicarbonate again. In considering active bicarbonate replacement, three questions should be considered. What are the deleterious effects of acidemia and when are they manifested? When is acidemia severe enough to warrant therapy? And how much bicarbonate should be given and how is the amount calculated? Deleterious effects of acidemia are decreased myocardial contractility, fall in the cardiac output, fall in blood pressure, pulmonary vasoconstriction, decreased binding of the norepinephrine to its receptor. Acidemia may adversely affect the cell functions such as enzymatic reaction, ATP generation, fatty acid biosynthesis and bone formation and resorption. Drugs which are salts of weak acids are more active during acidemia and more receptor binding, more intracellular cells. Best examples is the ASA, Calcitonamide, methotrexate and phenobarbital phenytoins, and they are causing more toxicity in acidemic patients. Optimal extracellular pH to be maintained is 7.4 and intracellular pH to be maintained is 7.1. And deviation from the normal pH will obviously decrease the efficiency of all reactions. Acidemia protects the central nervous system against seizure, but it sensitizes the myocardium to the anxiogenic effect of the norepinephrine and epinephrine. And extracellular pH is surrogate for intracellular pH. When acidemia is severe enough to warrant therapy, most authorities in acid-phase physiology would give bicarbonate to a patient with an arterial pH of less than 7.1. Not a hard and fast rule, and more on this later. And how much bicarb should be given and how is that amount calculated, I'll talk about later. And it has been said that at pH of 30 ml of mercury and bicarb of 4 microgram per liter, the arterial pH is 7.1, that is calculated. And raising the bicarbonate to only 8 microgram per liter, the blood pH will come to the level of 7.4, and which is very much important in maintaining the exact cellular functions. And this assumes the pH will have not changed. The AHA has revised the guidelines on sodium bicarb since the 2000 edition of standards and guidelines for CPR and emergency cardiac care. Bicarb is only advised at the discretion of the physician directing the resuscitation. While the AHA does not recommend the routine use of bicarb, the research oftentimes contradicts itself. As early as 1962, researchers reported cases of patients in ventricular fibrillation that were in acidosis and remained refractory until the acidosis was corrected with sodium bicarb. This demonstrated that it's highly unlikely to resuscitate the fibrillating heart if severe acidosis is present. This has resulted in a debate over whether acidosis causes the cardiovascular system to be less responsive to medications. Efficient ventilation and adequate perfusions are the principal determinants of the acidosis. Part of the concern is that since sodium bicarb produces carbon dioxide, it may actually worsen the acidosis. Carbon dioxide, when combined with water, forms carbonic acid, which is a weak acid that diffuses across the cell membrane easily, whereas sodium bicarb cannot. Because sodium bicarb produces carbon dioxide, EMS provided there is emergency medical service provided can expect a sudden increase in their patient's carbon dioxide level immediately after administration of sodium bicarb. This is the underlying reason why sodium bicarb is not recommended for patients who are not being ventilated with definitive airway barrier. For the patients with ongoing end-stage carbon dioxide monitoring, carbon dioxide level should return to a pre-administration level after several ventilation, and that should not be a problem to the persons who are administering sodium bicarb to the acidic patients, because we are observing the end-stage carbon dioxide level. Because bicarbonate crosses the blood-brain barrier, concerns have been raised about creating an inadvertent hypernatremia, which is an elevated sodium level with the use of sodium bicarb. If that were to occur, it would decrease the cerebral perfusion pressure. However, recent studies have also demonstrated that this only occurs on a limited basis. Animal models have been given as much as 4 to 6 microgram per liter per kg without adverse sodium shifting. For example, it would take 8 ampoules of bicarbonate to reach the 4 microgram per kg level in a 220-pound patient. Hence, we are using bicarbonate in a lower amount in our ICU, so that hypernatremia should not be a concern. Sodium bicarb administration in conjunction with epinephrine was reported to increase the survival as early as 1968, with more recent studies demonstrating similar results. This was confirmed in 2005 when fixed-probe researchers found that emergency medical system administered sodium bicarb with epinephrine within minutes of resuscitation demonstrated a higher rate of survival, higher discharge rate, and better neurological outcome. So, CETUS continually demonstrated one of the highest survival rates for patients suffering cardiac arrest, the out-of-hospital setting, and bicarb was the choice there. And recent interest has focused on neurological outcome and protective results in survival, and sodium bicarb combination combining with the norepinephrine and epinephrine will provide the maximum outcome. Patients who have overdosed from the tricyclic antidepressant, diphenhydramine, aspirin, therapy, and cocaine have potentially toxic effects and have benefits from the sodium bicarb. So more researchers agree that in case of cardiac arrest where acid-base status was normal prior to a cardiac event and the patient responds promptly to such standard therapies as defibrillation and ventilation, sodium bicarb use is not warranted. However, in case of prolonged cardiac arrest of greater than 10 minutes from the time of sudden death, it appears that the use of sodium bicarb is warranted in the presence of adequate ventilation and good chest compression. And to conclude, I want to say that bicarbonate therapy should not be thrown into garbage, and bicarbonate should be used with critical evaluation and adequate ventilation, and everything old is not trapped. Respect the old so that we will be respected. Thank you.
Thank you, Dr. Bhattacharya. Now we have Dr. S.V. Chattopadhyay, who is speaking against soda bypass therapy in critical illness patients.
Very good morning to respected chairperson, respected seniors and their colleagues. My topic here is bicarbonate therapy is helpful in critically weak patients, and of course I am speaking against this. In reality, nothing comes in black and white. My previous speaker, who also happens to be my colleague senior, talked about some white things about bicarbonate, and I will talk about some black things, and you will determine how grey it is. So in our practice, safety always comes first. So first check, bicarbonate therapy, how safe it is. Sodium bicarbonate is a hypertonic and hyperosmolar solution. It comes as a 1 millimole per ml solution, and this hypertonic sodium solution during the left ventricular contractility should always be infused slowly. Hyperosmolality redirects fluid from extravascular to intravascular site, increasing myocardial preload. And effect on cardiac output is unpredictable, and often in weak heart, the left ventricular failure may be precipitated. Bicarbonate therapy also causes hypercapnia and intracellular acidosis. Yes, it may cause paradoxical acidosis. Infused bicarbonate ions combined with hydrogen ions will release carbon dioxide. And this carbon dioxide diffuses rapidly across the cell membrane, and it worsens intracellular acidosis. Healthy humans hyperventilate in response to hypercapnia and maintain an arterial PCO2 within normal limits. But we are not infused bicarbonate in a healthy individual. Our critically ill patients with shock and acidosis are sedated and mechanically ventilated with a fixed minute volume. So they are unable to eliminate carbon dioxide load. In these patients, arterial and mixed venous PCO2 often increases. Patients with cardiac arrest with decreased cardiac output after bicarbonate infusion, also PCO2 further increases, and bicarbonate therapy causes myocardial intracellular acidosis, and the cellular function paradoxically worsens during therapy. It also causes ionized hypocalcemia. Sodium bicarbonate infusion decreases plasma ionized calcium concentration by increasing the pH and thereby increasing the binding between calcium and albumin, and also by chelation of calcium. This problem is marked in patients who already have ionized hypocalcemia, like patients with lactic acidosis, and this ionized hypocalcemia decreases myocardial contractility. Thus bicarbonate infusion may paradoxically decrease myocardial contractility. It also decreases oxygen delivery to tissue. Acidosis shifts hemoglobin dissociation curve to right. It favors oxygen unloading to tissue, and by increasing pH, bicarbonate shifts the dissociation curve left and impairs this benefit. It causes rebound alkalosis. When lactic acidosis later reversed, patients with cardiac arrest when successfully resuscitated, the accumulated lactate is metabolized to bicarbonate. If bicarbonate has been infused earlier to increase pH, metabolic alkalosis occurs during recovery, and metabolic alkalosis impairs tissue oxygenation and associated with increased motility. It also causes increased lactate production. Like acidosis slows the rate limiting enzymes in the glycolytic pathway, that is phosphofructokinase, and thereby slows lactate production during anaerobic metabolism. If acidosis is reversed, but the cause of anaerobic metabolism is not corrected, then hepatic lactate production is accelerated. Then I am coming to my next part, that is bicarbonate therapy, how useful it is. I will talk regarding metabolic acidosis only, the controversial part. So let's check the American Heart Association guidelines. The recent ACLS guidelines say sodium bicarbonate not recommended for routine use during cardiac arrest. This is a paper by Cooper bicarbonate does not improve hemodynamics in critically ill patients who have lactic acidosis, a prospective controlled clinical study. And they concluded by correction of acidemia using sodium bicarbonate does not improve hemodynamics in critically ill patients who have metabolic acidosis and increased blood lactate or the cardiovascular response to infuse catecholamines in these patients. Sodium bicarbonate decreased plasma ionized calcium and increased PaCO2. Another study by Forsyth by sodium bicarbonate for the treatment of lactic acidosis, they concluded that we find that often cited rationale for bicarbonate use, that is, might ameliorate the hemodynamic expression of metabolic acidemia, has been disproved convincingly. Further, given the lack of evidence supporting its use, we cannot condone bicarbonate administration for patients with lactic acidosis, regardless of the degree of acidemia. Now coming to diabetic ketoacidosis, this is a study by Zeni. It goes like this: does bicarbonate therapy improve the management of severe diabetic ketoacidosis? And they draw the conclusion by saying, data from the literature and this study are not in favor of the use of bicarbonate in the treatment of diabetic ketoacidosis with pH value between 6.90 and 7.10. Another study regarding bicarbonate therapy in severe diabetic ketoacidosis, which concluded by saying, we conclude that in severe diabetic ketoacidosis, arterial pH 6.9 to 7.14, the administration of bicarbonate does not affect recovery outcome variables as compared with those in a control group. The list may be ended. Now coming to the third part, are you doing our math right? Are you calculating the base deficit or excess correctly? It is a case report from UK where a 34-year-old female, known case of upper intestinal fistula with high output, controlled with codeine and loperamide, recently experienced flu-like symptoms and above medication were taken. On presentation, she was breathless but not looking distressed, respiratory rate around 30 breaths per minute. She had low grade of pyrexia, generalized body ache, urine output was markedly decreased, and clinical examination more or less within normal limit. So first differential diagnosis was like septicemia or pulmonary embolism. The CT abdomen within normal limit, pulmonary CT angiogram again within normal limit. The ABG picture shows like this: pH 7.11, gross acidosis, PaCO2 21.5, PO2 141.75, bicarbonate 4.4, lactate 1.2. So bicarbonate is severely decreased and pH is gross acidosis. Patient received, so this is a case of gross metabolic acidosis with compensating bicarbonate, compensating respiratory alkalosis. Patient received slow IV infusion of sodium bicarbonate, but there is no improvement. Other parameters are like sodium 127, chloride 109, albumin 36 gram per liter. Here comes a new approach. It's called Stewart approach. Peter Stewart, a Canadian physiologist, suggested a new way of looking at acid-base physiology, where there are three independent variables that affect hydrogen and therefore pH of the body fluid. They are carbon dioxide, strong ions like sodium, potassium, magnesium as cations, and anions like chloride, sulfur, lactate. And they take the difference that is called SID, or a strong ion difference, and the total concentration of weak acids are taken. This is termed as A total, and the A total is mostly affected by albumin. The seed is measured, and the most important difference from traditional approach, that the Boston approach or the Danish approach, is that the change in pH are not determined by addition or removal of hydrogen and bicarbonate, but are the result of change in the independent variables, that is CO2, SID and ATOT, and bicarbonate here considered as a dependent variable. To use this approach as a bedside, we need the following: base excess as measured by the standard blood diagnostic machine. We calculate SID by sodium minus chloride minus 38, where 38 is the average value, and sodium and chloride are the ions and most influence SID. We calculate albumin by albumin effect by 0.25, 42 minus measured albumin, and the true base excess is determined by measured base excess minus SID plus albumin. And returning to the case, we can see the patient has a severe metabolic acidosis with normal lactate compensated by a respiratory alkalosis as described by traditional approach. However, the etiology of acidosis is unclear. The patient was hyponatremic with high normal chloride level. Patient was losing large volume of upper GI fluid, also got normal saline infusion day before. Applying this data, we get the SID effect like -20, and after calculating everything, we get the true base excess like -4 millimole per liter. So there is not much bicarbonate deficit, but patient, as the SID is narrowed here, most of the patient's metabolic acidosis is accounted for by the narrowing of the SID. Her GI fluid losses were replaced by renal lactate over a period of 2 days. The fluid replacement and slow correction of sodium. After 36 hours, the respiratory rate back to normal. There was normal urine output, and there is mild background acidosis due to chronically low sodium. So coming to the conclusion, the acid-base disturbance must never be interpreted in isolation, but always with reference to clinical condition. The best way to treat any acid-base abnormality is not by bicarbonate, is by treating the underlying pathology or disorder, always. The Stewart approach, although not perfect, affords the best quantitative tool for assessment of acid-base disorder. Thank you for listening.
Thank you, Dr. Upadhyay. Now we have Dr. Part9 here, he is a nephrologist, working in ICU. Just to conclude both the speakers, both the topics.
Before that, I ask you, Dr. Satyajit, do give the background therapy in all the patients, diabetic acidosis, lactic acidosis? And lactic acidosis, what is the therapy? What is the best line?
I am against bicarbonate therapy, first of all. And here the studies are regarding in a severe acidosis situation. And also in that situation they have found that it has very little benefit.
Sir, guidelines are made by few people. We are not there to take their view all the time, because ACCAT guideline has started from 1970 and they have changed the guideline every 5 years. So their guideline is not for, that means this is the end and every all. So we must conclude and we must think about the critical situation, and we can use the bicarbonate whenever we think that is possible and clinically correct. We shouldn't follow some guideline blindly, because we are the end user and we must put some clinical data so that ACCHA next in 2015 they can change their guideline again. We are there to provide the input as the end users.
When the acidosis or the lactic acidosis, lactate or ketone body, once the clinical situation improves, they convert to the bicarbonate. So earlier it is not required, it should be individualized.
Sir, that should be, every therapy should be individualized. There should be no blindfolded rule.
Only if it is wrong alkalosis
Okay. So according to this work, is there any comment or discussion? Then you can conclude. Yeah. Mike, please.
My question is to Dr. Chattopadhyay. You have been talking against bicarbonate. So have you heard anything about carbicarb? Have you got any of
Carbicarb also can.
Yeah. So
that does not be, but it is not really available in here, and I have not used it. I have no experience regarding it.
but
It does not increases the PCO2 level. That's the good thing about it. But there is no evidence supporting that it improves the outcome of any acidosis.
But if you search the literature, you can see that when carbicarb have been used, when it has been compared against bicarbonate, these lactate levels were stabilized, and the pH levels, the rise of pH levels was much better in patients who were treated with carbicarb. So I think when you have been speaking against that bicarbonate,
It's a good option. It can be a replacement for bicarbonate, sodium bicarbonate. But still now there is no conclusive evidence yet.
okay. That could have been you could have added that point so that you could have more, you would have been more justified in totally being against.
As the motion goes about bicarbonate used in the acidosis, I am not mentioning that.
one thing I will add to this, one is bicarbonate chloride to be given only one condition, inarticular acidosis, it is to be given. That is a regular and chronic process. The second point is to keep in mind, when it is equal to the pH less than 7, it should be indicator for go for the bicarbonate chloride, and the level should be 7.2. That was these two things I will tell and we get a conclusion.
Well, the urge to give soda bicarb in patients with metabolic acidosis is almost irresistible. Many of us have come across, we automatically, when patients have RX, we always like to add soda bicarb. Along with we give adrenaline, we give xylitol, then we will give the soda bicarb with the calcium. So that it's not, now it's obviously it's a grey area, may not be helpful, has got its own ill effects. And other things are more important, like treating the cause first. Patients should be well oxygenated, they should be oxygen given to the tissues, and patients should be well mechanically ventilated. Without mechanical ventilation, don't even think of soda bicarb. And in renal tubular acidosis, obviously patient is losing soda bicarb, so we should give. But in cases with ketoacidosis, metabolic acidosis, one should consider giving only when the pH level is very much low, only then Thank you, doctor. Thank you, Dr. Bhattacharya. Thank you, Dr. Upadhyay. We have a very wonderful topic next, and we have very eminent speakers coming on to the stage to speak this topic. We have analog insulin versus conventional insulin in ICU settings. And we have Dr. Sujay Majumdar, MD FRCP, consultant endocrinologist, who will be speaking for conventional therapy. And we have Dr. Kalyan Ganguly, MD MRCP, consultant diabetologist, Fortis Hospital, Kolkata, who will be speaking for analogs of insulin. I welcome you both, sir. Please come in.
Both are eminent endocrinologists in the city. So everyone knows Dr. Ganguly and Dr. Sujay.